you very much. And I'd just like to thank the organisers of the conference for the invitation and the ability to come here to speak. This is actually my third attendance at OCCUCON, and I was last here in January 2020 when we were all talking about a new virus, and I don't think any of us realised the impact that that would have on all of our working and personal lives. At that time, we signed a memorandum of understanding between the Society of Occupational Medicine, I was president at the time, and because of events, really we didn't progress that very far. We re-signed that protocol last year, and now Dr. Shruti is president. We're looking to take that relationship between IAOH and SOM forward in the future. And I look forward to attending future conferences as well. What I want to talk about today is health risk assessment and the part it plays. And I'm going to illustrate that by talking about health risk assessment in the health service during the pandemic and some of the lessons that we learned from that about how we manage health risk assessment and how we need to improve in the future. Health risk assessment is an essential tool in managing occupational health hazards. And it's all about identifying, assessing and controlling those hazards and having a documented system to do that. As well as being good medical practice, this is actually a legal requirement in the United Kingdom. So you have to have a documented health risk assessment saying how you manage your health hazards. And that is also true for biological health hazards such as COVID. Back in 2020, we had a novel virus. We didn't actually know that much about it, so we had to make assumptions. And I think where you were in the globe, depending on what assumptions you drew, in Europe we were prepared for a influenza pandemic. We assumed that the virus was going to be like influenza. I think in Asia, people had experienced the SARS epidemics previously, and they assumed the virus would be closer to SARS. And in fact, that proved to be the case. And therefore, I think in the early phases of the pandemic, Asia managed the virus better. We didn't understand that significant proportions of the population would be asymptomatic carriers of the virus, although we did have an assumption that the elderly and vulnerable would be most effective, and that actually proved to be the case. So when we started off, we applied COVID controls, some of which proved to be appropriate, others not. We assumed that fomite mode of spread would be significant, as it would be for influenza, so people touching objects and then picking up the virus and transferring it. We also assumed that aerosol-generating procedures would be significant transmitters of the virus. Both of those assumptions proved to be not completely incorrect, but certainly less significant than we imagined. At the time, certainly within Europe, mask wearing for the general population initially wasn't recommended. Lockdowns were applied in China and Asia very early on, and we followed later in Europe, and in the case of the United Kingdom, we were actually slower than the rest of Europe. And it was only when a study was published by Imperial College saying that there could be significant numbers of deaths, over 1 million deaths from COVID, that we actually followed the rest of Europe into lockdown. It's worth noting that Sweden never locked down. Temperature screening was widely used. Travel bans were introduced early, although the WHO recommended against them. And testing regimes were initially very limited because there were no tests available. Lockdowns were implemented and schools closed. Despite all of that, within the health service, we had significant morbidity and mortality among the working staff. So by the end of 2020, nearly 1,000 healthcare workers had died of COVID. Some of those would have been community acquired from home or other places, but we have to assume a significant proportion were actually work acquired as well. And certainly the fatality rate among healthcare workers was greater than the general population. There were other occupational health groups who were also suffering high rates of COVID. Bus drivers was one, and another one were workers in meat processing facilities. But for the sake of this presentation, I'm going to concentrate on healthcare. one of the things was that during the initial phases of the COVID pandemic, healthcare workers continued to go to work even though we knew the protections were inadequate. And that continued in the United Kingdom, and there was a lot of debate about what protections were needed to be in place. And healthcare workers were rewarded by the whole communities would go out and clap for them in the evening. Every Tuesday evening they would have a clapping session for them. And this is an opinion piece that was written by an Australian observing this. He called for an immediate end to the rhetoric of healthcare workers as heroes, identifying it as a damaging distraction from the legal and moral imperative to accord healthcare workers the same standard of occupational safety enjoyed by workers in other industries, such as construction or mining. In UK, the sanguine acceptance of healthcare workers' harm by the public, the NHS, the government, and also by healthcare workers themselves had been an awesome sight to behold. So what he's saying there is healthcare workers continue to get on with the job, but actually rather than kind of rewarding them for bravery, what we should have been doing is putting better protections in place. As a response to that, the healthcare unions and some in government and also the media immediately asked for better and higher quality PPE. And certainly PPE was part of the problem. We needed to have a good assessment of PPE. But as we know as healthcare professionals, it's not the complete answer. And in fact, it's one of the lower levels of control in the hierarchy, and I'll come back to that later. So we need to have a comprehensive risk assessment addressing the whole of the exposure and looking to put controls in place, and PPE is a part of that. So these are the results of an inspection that was carried out by the Health and Safety Executive in December of 2020, so roughly 8 or 9 months into the pandemic. They inspected 18 acute hospitals. The Health and Safety Executive is the UK regulatory authority, and what they found was worrying. So of the 18 hospitals they inspected and their health risk assessments, only 5 were fully compliant. 4 had advice given, and 8, which is nearly 50% of the total, had improvement notices issued.
Excuse me, your slides are not moving on the screen. Are you sure you want to show this slide? Yeah, what you're explaining and slides are not in sync.
Sorry.
Thank you.
So only less than half were fully compliant. There was a lack of understanding of the risk assessment process, a lack of understanding of the hierarchy of controls. There was need to improve how risk was managed. Employees were not clear on what constitutes a PPE programme. And in many places, only the clinical areas had been covered. So areas away from the wards were not covered, such as offices and breakout rooms. There was also confusion about what an HRA should achieve. Different groups had different ideas on that. Occupational health staff were carrying out risk assessments for vulnerable staff. The infection and prevention control staff were carrying out assessments to prevent nosocomial infections, to prevent the staff infecting the patients, but weren't focused on the workers. And also HSE staff were carrying out assessments, but were not necessarily completely well informed. PPE was seen often as the main or only control, and even then it wasn't properly implemented. The quality of the PPE was very variable. Often it changed. PPE wasn't being fit tested, and there was a lack of training for staff in how to correctly use the PPE. There was a lack of application of the hierarchy of controls. In the case of COVID, it wasn't possible to completely eliminate the virus, but we could reduce the exposure to infection by using testing, by isolation of those who were positive, by keeping staff who were positive away from work. Substitution wasn't possible. Engineering controls with ventilation and barriers was possible. Administrative controls in terms of separating the infected and non-infected, and also correct use of PPE. It was also necessary as the pandemic progressed to update the HRA in base of new knowledge. So some of the early theories proved to be incorrect or not so strong. So the fomite theory, not wearing masks for public use, surgical masks being used for, only surgical masks being used for healthcare workers, those with infections would have symptoms, temperature screening, all of those proved to be either weak or ineffective controls. And we needed to move on and adopt such things as ventilation, face coverings in public, enhanced PPE for workers, including RPE, FFP2 and FFP3, control in all areas, including breakout rooms, and vaccination and testing. We also needed a plan to control those measures, and I think that's just been very graphically demonstrated in China, where they've made a massive change in their control measures from COVID-0 to removing all controls, and that's causing a huge wave of infection currently, although we're not quite clear on the effects of that. Also, learning from incidents is very important. Also, learning from other industries. So learning from incidents, looking at the airline industry are very good at that, and I think that's something that other industries could learn from. This is a health risk assessment example methodology from oil and gas, a bow tie methodology. So looking at adopting other methodologies from other industries to help in the risk assessment process. So lessons learned, we need to have competent, experienced people. BOHS carried out a survey of the health services. Shruti was saying over 1 million people working in healthcare. If we take into account social care, it's over 2 million people. There were 3 certified occupational hygienists working for that whole population. So we need to have more competent people working in this. I think a lot of physicians, they did some risk assessment training as a part of their initial training in occupational medicine, but perhaps hadn't used that for many years. So there was a need for refresher training. And greater awareness about health hazard management among safety professionals who do a lot of the risk assessment work. We need comprehensive risk assessments of examining all potential areas of infection, application of basic principles such as the hierarchy of controls. We need to adopt best practice from other industries, airlines and oil and gas, and we need the flexibility to change controls. And I also put here, there's a large inquiry going on in the UK into the COVID pandemic and lessons learned, and you know, HRA should be included in the scope for that inquiry. So my last slide is just there are resources available on the SOM website, both on pandemic but also more broadly on occupational health as well. Thank you very much.